My name's Sonia, I'm one of the education and training pharmacists. I'm just going to very quickly talk to you a little bit about medicines management and pharmacy in general. Okay, so just talk about a little bit about the zero tolerance policy, some of the national alerts that hopefully you're all aware of, medicines reconciliation and the pharmacy service that we provide here. Okay, so the GMC states that all doctors must keep clear, accurate and legible records, reporting relevant clinical findings, decisions made, information given to patients and any drugs prescribed or other investigations or treatments. Okay, so administrating or dispensing against an unclear prescription within the NHS in the past has led to serious patient harm and resulted in charges of negligence and disciplinary action against healthcare professionals involved at all stages. So all prescriptions must be clear, accurate, safe and appropriate. Okay, so as part of the zero tolerance procedure, you need to print in clear, legible handwriting, include the full drug name and specify the dose units in full. So you should always write micrograms in full and units in full, never ever abbreviate them. Okay, so we've got a zero tolerance approach and then we've got two forms that you might see attached to prescriptions. If you ever see a blue form attached to a prescription, that means pharmacy haven't dispensed medication against that prescription because it doesn't meet the minimum prescribing requirements. So it needs to be rewritten before we can dispense that medicine. The exception report is the pink form that you might see attached. So this is when pharmacy have dispensed medicine against a prescription that isn't acceptable, but nursing staff won't be able to administer against it. So we might do that if that's the critical medicines, the Parkinson's, epilepsy, antibiotics. So they'll physically have the drug on the ward, but nursing staff won't be able to administer it until you've amended the prescription. Okay, that's just an example of a badly written prescription that's from this hospital. So obviously just make sure it's clear. So don't abbreviate drug names. So ferrosulfate, isobimodonitrate, that's another one that's commonly abbreviated, which isn't allowed. Okay, so the National Reporting Learning System is a central database which holds all patient safety incidents and reports. They analyse these reports and they influence healthcare organisations to make changes to prevent these from happening again. So some of the alerts that they've been involved in are around insulin, anticoagulants, methotrexate, lithium and potassium. So I'll just talk about a couple of them. So in 2010 there was a rapid response report around insulin. So they had 16,600 patient safety incidents reported, which included death. 26% of these were due to an incorrect dose, strength or frequency. So when you're prescribing insulin, you always need to have units in full. You need to have the word insulin on there somewhere. And if you're ever administering insulin, you need to make sure you use an insulin syringe, not an IV syringe. Okay. So anticoagulants are a high-risk medicine, so they're most frequently identified as causing preventable harm and admission to hospital. So it's making sure you follow trust procedures. So warfarin, if anybody started on warfarin, making sure they counselled appropriately. So just thinking about what you would like to know if you were started on warfarin. So telling the patient about what tablets, the different colours and strengths they come in, the fact that the dose isn't going to be on the box, it's going to be in the INR booklet. There isn't, have you all seen the information counselling pack for the yellow ones? No? Okay, so every ward there'll be an information pack. Every patient who's newly started on warfarin needs to have a counselling pack given to them, and then there's a form that we need to sign to say we've counselled the patient on warfarin. Doctors can do that, pharmacists can do that, and nursing staff can do that, but between us we need to make sure somebody's counselled them on warfarin and the patient's happy, and on discharge we need to refer them to the anticoagulant. Okay, so the DOACs. So apixaban, rivaroxaban, edoxaban, dabigatran, you will start to see these more around and about now. Again, if somebody started new on an anticoagulant, you still need to counsel them appropriately. You do need to refer them via the ADAS system again on discharge. there isn't a form that you need to sign, but you do need to make sure the patient is aware that they've been started an anticoag drug and you've done the appropriate referral. Always double check with the DOACs, make sure they're not on dalteparin at the same time. That's a common interaction that sometimes gets missed, so you should never ever be on a DOAC and dalteparin together. Methotrexate, so we have a methotrexate policy, and make sure you're aware of it. When you're prescribing it, make sure you cross out all the days you don't want the patient to have it. Methotrexate is a great drug, but if you get it wrong, we can cause serious harm to a patient. Okay, opioids, again, high risk medicines. So you need to make sure if you're prescribing modified release preparations that they are prescribed 12 hours apart, so morning and night time, not morning and evening. Different routes of administration are not equivalent. So if you're prescribing somebody morphine on the PRN side and you want to have an oral alternative, oral and an IV alternative, you need to have two separate prescriptions because the dose is not equivalent. IV is twice as potent, so you can't have it all in one prescription. And if you're calculating breakthrough doses, make sure it's a 6 to a 10th of the regular opioid dose. Medicines reconciliation. So this is the process of identifying an accurate list of medicines that the patient was taking, recognising any discrepancies and documenting any changes that have been made. So this is where you would find the drug history in the patient's notes. Ideally, you need to use at least 2 resources to complete a drug history. So patient, family, carers, nursing homes, GP records, patient's own drugs, etc. If a pharmacist or somebody from pharmacy has seen this, they will normally complete this in green ink and sign and date it in green. Just be aware that technicians can also complete drug histories. So just because you see green ink doesn't necessarily mean a pharmacist has seen this patient. It just means that a drug history has been completed by somebody from pharmacy. If a pharmacist has seen the patient, they will sign at the back of the prescription chart and each drug clinically to say that that's okay. Okay, so on discharge, you need to make sure you complete all the relevant boxes. So all new medicines, making sure we state why they were started, and making sure you fill in the discontinued medicines with reasons, and any dose changes are documented. When you go onto the discharge system, it won't actually let you complete until you press add, so you need to make sure you press add. You also can't add another item in until you have something in the reason box, so you need to make sure that you complete all the boxes. Okay, so there's lots of policies that you need to be familiar with in regards to medicines. I'll show you where you can access those in a second. Useful resources, so EMC, BNF, up-to-date, Talkspace, and again I'll show you where you can access those on the internet. Pharmacist intervention notes. So pharmacists will leave yellow intervention notes stapled to the front of a prescription chart if there's any advice, any meds that are missing, any monitoring requirements. Once you've acknowledged them, please will you just tick them or sign to say you've acknowledged them, and then the pharmacist, once they know the changes have been made, they will take the yellow notes off. Okay, so the pharmacy service. So we open 7 days a week, 8:45 to 5 p.m. Pharmacists will visit almost every ward, Monday to Friday. We have a pharmacy-led discharge service on the medical ward. So if anybody's on medicine, please speak to your ward pharmacist. They'll be able to tell you that. I'm sure you'll find it helps you massively. On the weekend, we only have 2 pharmacists working, so we only see the new patients and do discharges, so we don't go around all the wards as we do Monday to Friday. Every ward pharmacist will have a bleep, so if you've got any queries about any of your patients, your first port of call will be your ward pharmacist. If they're not answering back or you're still stuck, then you could contact Medicines Information on 53791. You might see one-stop technicians or assistants around on the wards from pharmacy. So the technicians and assistants normally wear like a greeny coloured uniform. They're there to order all the medicines. So they can't help you with any clinical queries, but they can help you with ordering of medicines if you're wanting to know, has this been ordered, has it come up, why has it not come up? And we do have an on-call service for out of hours. So if you're on-call and you need the on-call pharmacist, you need to go via switch and they'll get in touch with the on-call pharmacist for you.